And the doctor said, STN stimulation is so fantastic for the patient that you must do something. Yeah. So Medtronic was kind of forced to do something, and we designed an extension of the original study. We asked the operator of the MRI to change the parameters. Yeah. And he said, no, I have only tools provided by the manufacturer. And Peter and I looked at each other and said, okay, ask this guy to get a cup of coffee in the canteen of the hospital and come back in an hour. And what we did is we put the Medtronic salesperson who was there in the MRI machine, and Peter and I changed the parameters in the MRI machine, and in half an hour he had a beautiful T2.
T2, yes.
The next morning the radiologist was absolutely flabbergasted.
Wow.
My machine can make a T2. So I designed a protocol and sent it to Medtronic. It's called the Quest with capitals QUEST, Quest grant, and it is intended for activities that are crazy in their idea, where the existing Medtronic business units were absolutely not interested. And so I got the money from the top of Medtronic, $50,000 I got to design deep brain stimulation for obsessive compulsive disorder.
Welcome to Stimulating Brains.
Hello and welcome to Stimulating Brains. I'm delighted to welcome Frans Gielen, who is one of the quiet architects behind modern deep brain stimulation. Frans is a physicist and biomedical engineer by training who spent more than 3 decades at Medtronic during the formative years when DBS evolved from an experimental idea into a globally accepted clinical therapy. During that time, he supported and trained teams while attending more than 2,000 DBS implantations worldwide, often working hands-on in the operation room at a time when stereotactic imaging, targeting, and surgical workflows were still being invented in real time. Crucially, Frans was not only involved at the technical level. It is little known that he designed and managed several of the pivotal clinical studies that ultimately led to CE marks in Europe and FDA approvals in the United States. These include the landmark VIM DBS trial for tremor, enrolling nearly 300 patients, as well as the advanced PD study targeting STN and GPi, which helped establish DBS as a standard therapy in movement disorders and was published in the New England Journal of Medicine. This was not enough for Frans, who next had the idea to apply DBS in psychiatry and initiated and led the first clinical trial for DBS in obsessive compulsive disorder, which again led to CE and FDA approval in form of a humanitarian device exemption. Finally, later, he designed the MORE trial, which was the first application of DBS for epilepsy, also resulting in CE mark and FDA approval. These 2 studies shaped how neuromodulation entered psychiatric and epilepsy care. Many of the DBS indications we now consider established were at the time high-risk ideas that required not only engineering solutions but also regulatory strategy, clinical rigor, and persistence. And we have to thank Frans, most especially in the case of OCD, which was really originally his idea, that the therapy exists today. Throughout his career, Frans bridged worlds, engineering and neurology, imaging and surgery, industry and academia. He introduced microelectrode recording systems into DBS workflows, trained radiologists to optimize MRI protocols for stereotactic accuracy long before this was standard, and is inventor on more than 35 patents, most of them directly related to DBS. Even after retiring in 2022, Frans has remained scientifically active, contributing to modern connectomic work, including studies on the connectivity of the ant nucleus for DBS in epilepsy, where he collaborated with Jürgen May and Volker Koenen, and thinking deeply about how brain networks process information, a question that continues to literally keep him awake at night. This episode is a rare opportunity to hear part of the untold history of DBS, which is often and conventionally told from a surgeon's or scientist's perspective, but this time focusing on the work of an engineer who helped make DBS work technically, clinically, and regulatorily across multiple indications. I would like to use the opportunity to thank Dr. Ali Sarem Aslani, who many of you may know, and who made the suggestion to interview Frans and put us into contact. When Günther Deuchel from episode number 5 heard about the endeavor to interview Frans, he endorsed it to the highest degree possible. And when I told Marwan Harris from episodes 3 and 33, he became excited too, even contributing a guest question for Frans. I must say that it is these interactions with dear colleagues in the field, be it academics or friends from industry, that keep me motivated recording these interviews, which, as you may imagine, do take quite some effort and time. I would like to thank you wholeheartedly for tuning in. If you like Stimulating Brains, feel invited to tell your friends about it. Or if you even would like to contribute to the project in any other form or way, please do not hesitate to reach out. I would also like to thank Ala Taha for producing this episode, and Niels Pacheco and Rui Omar, who, together with Ala, have volunteered to split the work of producing all episodes that we put out. Now I wish you much fun with Frans Gielen, and thank you for tuning in, Stimulating Brains. Frans, thank you so much for taking the time.
It's a pleasure.
To sit down and talk about your job that you did with Medtronic and your whole life filled with deep brain stimulation experience. I'm super excited. I met you when I was entering the field, and it's great to see you again.
Okay.
You look almost the same. You have not aged so much. And we are here in your home in Ekerade in the Netherlands, which is beautiful, and it's great to be here and talk together.
Yeah.
So, as you may know, I often start by asking an icebreaker question about hobbies. So maybe what would you do well, you're retired, but what did you do in your free time, or do you do now as a hobby?
Yeah. Okay. My first hobby was biking. I biked my whole life. Started biking at 5 years old, going to school until I finished high school. And in the university, I entered the biking club. I must have biked at least twice around the whole world, so many kilometers. And I don't forget it, because in the last 2 years I biked more than 11,000 kilometers in 2 years. Yeah.
And is that sport like?
No. Since I had Corona a couple of years ago, my legs are complaining.
Okay.
And so the biking is now with an e-bike, but still 100 kilometers in a day or so.
Fantastic.
Yeah. And that is the biking which I did my whole life. And second thing is sailing.
Oh, wow.
I started sailing on the university.
Yeah.
And the sailing was on an old ship that we had as a student club, an old cargo ship.
Okay.
And later we rented, with a group of people, we rented a boat. And there's a famous name of such old ships, it's called Scootje. In the north of the Netherlands, in Friesland, there is the famous Frans Gielen. And we rented such a boat and sailed on the north of the Netherlands. In German, it is the Wattenmeer.
Yeah.
We sailed all the way up to Denmark and crossed the Kieler Canal, the North Ostsee Canal, and went up to Copenhagen.
Wow.
Yeah.
Great.
So, and we also sailed in the fall in Croatia.
Okay.
Because the water is nice and warm.
Yes.
And more rough was sailing on the English Channel.
I'm sure.
And in the English Channel Islands. So
the Croatian shore must be it's wonderful, right? With all the islands and
It is nice. You sail on the Adriatic Sea. Yeah. If the wind is too strong, it can be pretty uncomfortable.
Okay.
But in between the islands, you could have strong winds, but no big waves, and then go very tipped with a sailing boat.
Okay, sure. Yeah.
Having a lot of fun. And we did that usually with 2 groups that rented identical boats, and then men, they go and compete.
Okay.
Yeah. So that is the sailing that I did. And in the back of my garden, you see honeybee colonies.
Yes.
I did, when I was in the university, I thought I need to do something besides studying.
Okay.
And
I have more than 50 years. I have honey bee colonies.
Wow.
And I do queen breeding, so trying to make them better, making them more friendly, that they sting less. And I have to deal with an invader. It's called the varroa mite. Yes. And I test them and things like that. And lately, regarding the honeybees, the invasion of the Asian hornet.
Yes, you told me about that. I see the book over there, right?
Yeah.
And you're expecting a call from a university about that, right? So you're deep into the topic, it seems.
Yeah, I've designed this year, contrary to a clinical study, but a scientifically based study to look at if you try to catch the queens, to avoid the queens of the Asian hornet, you try to reduce the number of nests that they make in the spring. Mm-hmm. And you do that with a pot with a small spacings. But you get also other insects in it. It's called bijvangst, additional catch.
Yeah, bijvang, yeah.
Yeah, and governments rely on a report made in the west of the Netherlands where the people did that report. It's called the ICE report. That is not negative information about ICE, but there are many people who complain about the ICE. It says that these Asian hornets are not a risk for people. Mm-hmm. But they have an enormous impact on biodiversity.
Of course. Yeah.
And finally, breaking the ice, gardening. Yeah. I used, in between my Medtronic job, I used to grow vegetables for my family.
Okay,
so,
great.
Biological, no fertilizers, no poison, and that was a hobby also.
Fantastic. Okay, and so you worked as an engineer who became embedded in surgical practice and clinical evidence generation very early on, and also at a critical time point when deep brain stimulation really was born. Mm-hmm. So that is a very rare and valuable viewpoint. How was it like to be exposed to and collaborate with pioneers such as Alain-Louis Benabid and Pierre Polack, and how was the landscape at the time in the field of DBS, or in the birthing field of DBS?
Yeah. It is not strange, because Benabid studied first physics, mm-hmm. and got a PhD in physics, mm-hmm. and then he decided to do medicine and got a PhD in medicine. And besides the medicine, I have more or less the same thing. My study is also, and PhD is in physics.
Yeah.
And so we went very well on together. So it was not strange that I did that. And so my master's degree in physics and biomedical engineering, together you may call it biophysics,
mm-hmm.
Was very much linked to what Benabid did. So we were on speaking terms, so to say.
Makes sense.
Yeah.
Maybe we can also start, how did you even get to Medtronic, and when? That was 1991.
Yeah.
Right?
After my PhD in 1987,
mm-hmm.
1983, I went 3 years to the United States as a postdoc, mm-hmm. and a research professor in Vanderbilt University. Ever heard?
Yeah,
that is one of the 5 most famous medical universities in the United States.
Naturally, yeah.
And there I did biophysics. Biophysics that was tailored to measuring the biomagnetic field of nerve fibers. Mm-hmm. And why the biomagnetic field of nerve fibers? Because just like in electricity, where you have the epsilon, the relative conductivity, mm-hmm. in magnetism you have mu zero, mm-hmm. which is for almost all, certainly biological materials, very close to 1. Mm-hmm. So if you would be able to measure the biomagnetic signal from, in our situation, a regenerating nerve fiber, you could objectively, because it was quantitatively very reliable, mm-hmm. you could measure how many axons regrow in a nerve fiber, mm-hmm. for instance.
Oh wow, okay.
Yeah, it was the biomagnetism that I was involved in. So my career went from pure biophysics University of Vanderbilt University, to pure physics in biomagnetism in Vanderbilt University, to biophysics in Erasmus University in Rotterdam, 5 years. And then I thought, maybe try commercial company. Yeah. So that is the only time in my life that I solicited, that I applied for a job. And I got the job in the Medtronic Bakker Research Center here in Maastricht. I got the job, and I think the only reason why I got it because I worked 3 years in the United States. That was considered to be, we are an American company, and the guy knows he knows how to behave in the United States. So that was how I went, and I started in Medtronic on the 1st of September 1991, and I was hired to run a clinical study in spinal cord stimulation for pain. And the electrodes are outside the dura in the spinal cord, which is a kind of a space because the dura is hanging a little bit, dangling a little bit, and these electrodes had the tendency, in some patients at least, to move. And so this was a study in so-called positive fixation techniques. And the study had tines on the tip of the electrode, plastic tines. And in my situation, I did a study, and the first patient that was implanted was in Sweden. And thanks to the fact that physicians have the tendency to not read clinical study protocols, which clearly said once you are in the patient, you cannot remove the stiff stylet in the middle. Now, this doctor did, and because of the design of the electrode, the stylet poked out, went through the dura right in the spinal cord. That was the end of the clinical study.
Oh, really? Wow.
Yeah. Okay. So that was a very, very severe adverse event. End of the study. And then Medtronic didn't know what to do with me. And my boss, an American, by the way, Keith Mullet, Keith Mullet told me, go to Grenoble because the team over there is all the time asking attention from Medtronic for the deep brain stimulation project. So I went to Grenoble in January 1992. And I learned from Benedict and from Pollack. I learned a lot. And we designed a clinical study. Benedict did at that time, he published in 1991, study in the Lancet of about 20 patients done in the VIM of the thalamus for tremor, Parkinson patients. And that was all done with a custom device. That was the famous Model 3380, the model with one bullet tip at the end.
And that was the same as for spinal cord, right? Or
no. The 33980 was an electrode that was contrary to spinal cord electrode, not very flexible. Spinal cord electrodes, you must be going around the corner and then go in and bend the electrode, steer with the stylet.
So it was a custom electrode for that trial?
Medtronic made it in 1987 for Benedict, and it is designed to go in a stereotactic frame straight to a target, as straight as possible. That was that electrode. About 20 patients were done, published by Benedict, and he did that besides two all in Parkinson tremor patients, because he tried also 2 essential tremor patients, but he considered that failures. It is essential tremor is by the nature also more difficult than Parkinson tremor. So, and then he came to me and said, I want to have an electrode with more contacts on it, like the spinal cord electrodes that had 4 contacts already, and Medtronic had an associated stimulator, the ITRL. ITRL 2, that could run 4 contacts. And he said, we want to have one. So then Medtronic designed the 3387. You may have heard about it. That was the initial DBS electrode, and that was a study. The study was initiated in May 92. It was the classical based. I didn't know anything about clinical studies as a physicist,
But you had one before, right? But
that was spinal cord.
Yes,
it's completely different than in the brain. And I designed a study, the deep brain stimulation study for tremor, and it was approved by 13 centers, 13 professors, most of the time, in 13 centers in Europe in May 92. And it was based on the classical Medtronic study in spinal cord stimulation. At that time, 60 patients followed for a year, 6-0. The enrollment went so fast that Medtronic in Minneapolis got interested. And first of all, I got a boss in Minneapolis above me, and he said, your design of the study is not good because you need 300 patients in the study. And why was that? The so-called statistical rule of thirds. Everything that you can imagine in your wildest thoughts that can go wrong in a clinical study, if that doesn't happen in 300 patients, it is not something of any relevance.
Okay.
Rule of thirds. So I needed to do, instead of 60, I needed to do 300 patients. The design was that in 1994, somewhere in 1994, all the patients were enrolled, and it was. In rather 60, it was 300.
Wow.
In 2 studies, because after I started the deep brain stimulation study, after maybe 10 implants or so, some doctors came to me and said, this protocol, the case report form, is way too thick and way too complicated. We cannot work with it. You have to design something else. And then we designed the so-called DBS basic study, which was only implanting in 3 targets, doesn't matter which target, but mostly for pain, and followed for 3 months.
For pain?
For tremor.
For tremor, okay.
But free. You could do, and there were, sorry for the say so, cowboys that had ideas to stimulate, just like before the era of chronic DBS, as Marwan Harris said, before the chronic DBS stimulation, there were all kinds of studies with a few patients, proof of concept, yes or no, but publication, and that was, in my case, was a 300 patient study in 1994. Somewhere in April or so, all patients were in, and then we needed 12-month follow-up for the DBS study. And we got a CE mark in somewhere April 1995, which was as planned, but 5 times as many patients. So it was an achievement that was not only for me, but it was such a dramatic success, and everyone could see it, that doctors, also for commercial reasons, went on and did this study.
That's a very fast time frame, right?
It's unbelievable fast.
Was this the study that was then published in the New England Journal of Medicine?
No, that was the DBS, the advanced DBS study.
Yeah, okay.
I finished this for a moment,
please,
because we got a CE mark.
Yeah.
And then Medtronic as a company, we have a so-called XCOM, that is the real top of the company. They need to decide whether they would give XCOM approval. And it came very, very close, despite of the dramatic good results, came very, very close that XCOM said, no, we are not going to give that to the market, because at that time we had about $1 billion revenue annual for mainly cardiac stuff, cardiac pacing and so. And they thought brain stimulation, risky, it brings the $1 billion pacing business maybe at a halt.
I see.
Yeah. So, but ultimately they decided to give XCOM approval. But we started the study in May 1992. And almost directly, in beginning of 1993, Benebit got a French government study sponsoring, approved by the French government, for DBS in the STN of the for advanced Parkinson disease.
Yeah.
And Benebit did 10 patients in that government approved study. And the last patient, number 10, was an absolute disaster. Already on the table, the patient got a bleeding, got in coma, and then 2 weeks later, the other side that was already in started also to bleed. It turned out that the patient had a coagulation disease, which was missed by the inclusion, but probably missed or not known or whatsoever. But it turned out that the patient had a coagulation disease. Yeah. Coagulation was not good in this patient. And then DBS came to almost complete standstill because the government said, you cannot do this anymore because of the risks. But ultimately Benabit continued its approval from the government in the STN, but then it was a Medtronic study. It's called the DBS, the advanced DBS study, which was for DBS in STN, for advanced Parkinson symptoms, of DBS in the globus pallidus interna. The globus pallidus interna was the hobby from our US doctors, and the STN, because of the seat of Benabit, was mainly done in Europe. And that study was also finished very fast, faster than Medtronic thought, and you had a 12-month follow-up also.
And you also designed that study? Or
I designed the study, in Europe together with a colleague that I got in the United States. The study in the United States was impossible because I'm not going to say that that's too negative, but it was impossible. I skipped some of the follow-ups, a day long every hour following the patients. Can you imagine that from a doctor?
That's a lot. That's a lot of work.
And the study, the European study, was finished, 60 patients, with a follow-up of 12 months. That was not ready. And the doctor said, STN stimulation is so fantastic for the patient that you must do something. So Medtronic was kind of forced to do something, and we designed an extension of the original study, which was kind of I think...
You mean just to include more people? Oh, wow.
Yes, but in a clinical study, Medtronic could give that clinical device, the electrode, could do that. So we did that, and we got CE mark, I think, in 1998. And 4 years later, there was FDA approval. So it was also a very positive study that ran like hell. Inclusion was enormous.
Wow. That's fantastic.
Very fast.
One quick question, skipping back a little bit. I heard once, but I don't know if this is true, that before Benabit looked into the STN, he did try the pallidum, but it didn't seem to work. Is that true? Do you know that?
That was probably initiated by Professor Siegfried in Zurich, Kliniek am See, who published, in his way, a 4-patient study and said, based on a 4-patient study with hardly any follow-up, globus pallidus stimulation is successful for Parkinson's disease. And that was an official publication. And Professor Benabit must have tried it, but came to the conclusion that globus pallidus stimulation is, and I consider that also far more difficult than STN stimulation. Although the STN is a whole lot smaller, but maybe because of the size of the globus pallidus internal, it is so difficult.
Because you might miss the sweet spot or something.
Much easier,
Okay, fantastic. Wow, okay, that was a tour de force. So what happened next? Or maybe before we go into the trials as well, how was the landscape of Medtronic as a company? I assume the DBS division at that time was very small because it was a new thing. Who were people that, formed that part, and then maybe how did it explode at some point?
Besides the salespeople that were responsible for selling devices, when it is CE marked, in the clinical study, every device one by one has to be assigned with all the paperwork, and that has to be done by me. I was at that time the only person working in Europe, and that was almost not a daily job, but an enormous job to assign all these clinical products. And I had a debate also with Medtronic because they said, okay, the whole system is investigational, including the stimulator. Yeah, this Itral 2, which was used at that time pretty widely in spinal cord stimulation. And I thought it was not clever to do that, because suppose, and it happened at some point, that, but not in the study luckily, that there is a flaw in an Itral 2. And if you call it clinical, you have to stop the whole clinical because a clinical product fails.
Oh wow, okay.
Yeah, and I said, you cannot do that, but I was not successful. People simply hoped that the Itral 2 had no problem. No. A few years after that study, it turned out there was a problem because someone made a cleaning mistake by point welding the battery to the electronics in the Itral, and when the battery is used, it swells a little bit, so it moves inside the housing, and the contacts broke.
Oh wow, okay.
And so then the whole Itral 2 was coming on a standstill. If that happens in a clinical study, then
it's all done. Okay.
Yeah.
God, we are lucky that didn't happen.
No, it was, in my opinion, the best stimulator that Medtronic ever had. I cannot really judge the percept at this moment. That is so new and so complex that we still do not know how it behaves under all kinds of situations. Yeah. But the Itral 2 had the longest battery life.
Yeah.
You needed to have 2 Itral 2s in the bilateral stimulation because you could only stimulate one quadrupolar electrode per Itral. Later we had the
Kinetra?
The Kinetra, and the Kinetra was even worse.
Okay.
Because of a battery life, it was it was not a well-designed product in terms of battery life. And the doctor saw that and started to complain. And that was one of the reasons why they went over to other companies like Boston Scientific and the predecessor of Abbott. Yeah, because they hoped, they learned from the marketing that their batteries were better. Okay. So Medtronic lost a lot of customers for DBS when these things were happening. Yeah.
Okay. So what happened next? The 2 successful trials now for VIM and STN for essential tremor and Parkinson's disease. Did the field directly explode? So I had Todd Langevin on the talk once, right?
And he was at some point my boss.
Okay.
He was the manager for all the DBS in the whole world in Minneapolis.
And he said something that struck with me, that inside Medtronic it was somewhat easy to fight for DBS because you could just show a video and the tremor stopped, right? So I could imagine maybe something similar happened also in the field, where this was a new technology that didn't need maybe big statistics to show that it worked, at least for tremor. Was there a lot of demand all of a sudden after the CE marks and FDA?
It went off like a rocket, deep brain stimulation, mainly because it did its own marketing. It was so clear that the symptoms with on-off, a tremor, and with advanced Parkinson's disease, people that were kind of wheelchair bound suddenly could walk. You have seen these patients,
of course.
And so its own marketing, and still there were millions of dollars spent in marketing.
Okay.
But we went on for a while with the Kinetra and not Synchromed, but the other dual channel, the Activa PC. Still having complaints about battery life forever. Now, that is not necessarily a bad technology, because these newer stimulators could do so much more, especially the Activa PC, run 2.
Sure.
Yeah. And they didn't want to have it too big, so they thought that the electronics were less power using. And so the battery in the Percept was not twice as big as in Itral 2. And battery life was a concern for a long time.
Okay, got it. What happened for you after these trials concluded successfully? At some point, you sent me an email that you trained you attended 2,000 DBS surgeries yourself. You trained lots of people. You trained radiologists for the imaging. So was it all of a sudden more a field job where you traveled a lot, and had to teach people how this works, or what happened next in your life? Essentially?
At some point, the DBS manager in Europe, Pino Carbone is his name. Maybe you have heard the name. He's working for the Focus Ultrasound company.
Okay.
You know that.
Insight-Tech.
Insight-Tech, yeah. At some point, Pino approached me and said, the DBS is not running well in Germany.
Okay.
Way below the plans for Medtronic. And he knew how my training was. And he proposed that I started working for the marketing division. And I thought, I'm going to work for the marketing division because if I do my job correct, I will also steal some money from them to do research.
Yeah.
And so I started working supporting customers in Germany. And in 1 year, Germany went from below the financial target to way above the financial target. Wow. And then Medtronic managers in Minneapolis said, that is apparently a very efficient way of making customers believing in a somewhat difficult technology. And so I got immediately two colleagues. You know Peter Abbenroth?
No.
Peter Abbenroth lives in Bremen and was for a long period my colleague in the field, training doctors. Initially in Europe, but for me it started already very soon in Japan, because I saw emails in Medtronic and a salesperson in Japan telling that she didn't get any support from Medtronic in Japan. And so I made a contact with her. She invited me, and from that time on I trained many doctors in Japan, which is difficult because the hierarchy in Japan, doctors towards an engineer, is like me. It is not so easy. Okay. But once you have shown that you know your job, then it goes also there smoothly. Yeah. And from there on, I did this based on the cost marketing paid me. I did training in India and South Korea and Thailand. You name it, the countries.
Yeah, I've seen the Excel file. It's very impressive. The sites that you've trained.
Yeah. And the training started always with the technology, because neurosurgeons knew what a stereotactic frame was. At that time they made lesions. And Benabit said, I'm not going to make lesions in an already sick brain, Parkinson brain. So he started deep brain stimulation. And so for that you need completely different imaging techniques. We started with Benabit and also the Amsterdam Center with ventriculography. No, with, how do you call it, ACPC based targeting. 2 points in a three-dimensional brain, and based on that, if you had a wide head or a very tall head, it was a kind of guessing to find the target. And there were no tools, so I learned to do completely manual target calculations based on the images from X-rays from the front and the lateral.
Wow. Okay. So no software.
No software, no frame link, not software like you have, nothing like that. And initially it started with the X-ray, plain X-rays, front and lateral. And then CT came in. And CT was not designed for deep brain stimulation imaging. First of all, if you told a radiologist, I need 1 millimeter accuracy, so at the very most 2 millimeter slice thickness. No, our machine cannot make it. And I do remember the period that the patient was with stereotactic frame in the CT, and you could make a slab of a certain number of slices, and then you had to stop the acquisition because the X-ray tube had to cool down.
Oh wow!
And then you had to make a second slab, cool down, and the third slide. The cool down was Wow. So it was very complex to do that. And then you had a three-dimensional picture of the brain, where you could not see anything besides the ventricles and the skull.
Yeah.
Yeah, and still you with a very good CT, but that came later, where you could see the internal capsule.
Yeah.
The nice thing about CT was that you could also add contrast. And in 3D you could see some of the blood vessels.
Of course.
Yeah.
Yeah.
So that is, it comes a little bit later. So CT and then MRI from 1995 on. 1995, MRI became suitable for deep brain stimulation purposes.
Yeah.
That was very late.
And you're right, yeah, absolutely. But it was probably a game changer because you saw soft tissue, but probably in the beginning it wasn't great quality, or
No. The MRI was made by the manufacturer for diagnostic purposes. And for a lot of diagnostic purposes, thick slices, 5 millimeter, were very standard. And distortions are not important. If you have a disease in your brain, if the brain is looking more crooked than it really is. But making an MRI initially without frame, because the frames were not considered to be safe at that time in the MRI, making an MRI with, say, maximum 2 millimeter slices, that was very difficult. You had to teach the radiologist to do that because the MRI manufacturers did not train doctors to do that because it was commercially not interesting. Deep brain stimulation was just a tiny niche in the whole business from using CT.
So I see. So the manufacturers wouldn't see a reason why you would need 2 millimeter slices for diagnostic reasons. That makes sense. Okay. And then you started collecting DICOM headers in a database, right? Yeah.
Because if the radiologists were not capable, they hardly knew what the DICOM header was. And if they ever saw that, the bulk of the radiologists didn't know what to do with it. And they got all the standard diagnostic imaging technique with CT and MRI from the manufacturer, and that's it. But if you needed to transfer the MRIs, for instance, to something suitable for DBS, I learned how to change the DICOM header. And then at some point, wow, fantastic image, that's what I want. And a T1 was considered to be least sensitive for geometrical distortions. And then I started collecting DICOM headers from MRIs, machines that spit out beautiful images. And I wrote somewhere that I have something like 176 DICOM headers from all kind of MRI machine in the world that I saw spitting out beautiful MRIs.
They're probably still valuable today, I could imagine.
They are. But I wrote also somewhere that DICOM headers were not a Medtronic product. Thus Medtronic managers and legal people said, Frans Gielen, you cannot give that to the customers because it didn't pass a clinical study for DBS. And then I remembered the beginning of custom devices. I told to the salespeople who begged me for this type of headers. I told to the people, tell me what kind of the salespeople, tell me what kind of MRI machine and model the doctor has, and I gave them a DICOM header from only that machine, and I considered that a custom device. And I thought it was, and it was never questioned. But also because I was very careful. I never promoted the DICOM headers, the whole database that I have, as a Medtronic product.
Of course.
That other people could use at will. It was always asking Frans Gielen to get something specific.
Makes sense.
Or I went to centers where we did it ourselves. I had a story from a center in South America, in Colombia, where the radiologist insisted that he had a modern MRI machine, insisted that his machine could not make a T2. At that time, there were no diagnostic tools for T2. Certainly not with thin slices. And I asked him whether we could get access to his MRI machine. Now that was not possible because they were doing the business, but ultimately we got access to the machine at 10 o'clock in the evening, including an operator for the MRI. And then Peter Appenoot and I, we were with the two of us, we asked the operator of the MRI to change the parameters. And he said, no, No, I have only tools provided by the manufacturer. And Peter and I looked at each other and said, okay, ask this guy to get a cup of coffee in the canteen of the hospital and come back in an hour. And what we did is we put the Medtronic salesperson who was there in the MRI machine, and Peter and I changed the parameters in the MRI machine, and in half an hour we had a beautiful T2.
T2, yes.
And the next morning, the next morning, it was intended to do the imaging for a patient in that hospital in Colombia. The next morning, the radiologist was absolutely flabbergasted.
Wow.
My machine can make a T2.
Oh, that's fantastic. I mean, it just shows this whole process how much the company and you as the executing person had to invest into making this a thing, right?
Yeah.
It wasn't a, how do you say, self-life, it didn't just go on its own. You really had to put a lot of activating energy into the system.
It was because it started with DBS in imaging, but in many other aspects from scratch. It was absolutely new.
Of course.
And so imaging all over the world. That was about the first thing I did all over the world, to go to the radiologist and say, let me see what you image here. Show me an example of a T2 and a T1 image. And very often they couldn't. So I helped them to design with my database, with DICOM headers. I helped them to design a T1 and a T2 that they could use. And they were almost always, they were absolutely grateful, because they learned something fantastic new. It was an important tool for the neurosurgeon in doing DBS.
And not even for DBS. I'm sure they use the sequence for other things too, right? So that's fantastic.
And so this was basically, in all centers where I went in the world, was training radiologists to make images. And then later training radiologists to make MRIs with an implanted DBS system, so that it is safe.
Yes.
The safety was also something brand new.
Yeah, that was very early on that Medtronic was MR conditional, right? Or the
conditional, it was probably after 2000 that we did something like that.
Okay.
Conditional, safe, and with a 1.5 Tesla machine, where soon 3 Teslas came in, and 5 and 7 Teslas came in. That was later. And radiologists, because they were no physicists, the bulk of them did not realize that the safety with an implanted DBS system went better and better and better the higher the B0, because the RF current that you use to excite the tissue is higher and higher frequency. And if you know something about physics, you know something about skin depth. The current flows, the higher the frequency, the more the metal is a kind of a sealer, and it flows to a very thin layer on the outside of the DBS contact, of DBS wires. So that was the physics behind to claim that the higher the B0, the safer it was to use these systems with implanted system. The only patient that got, not the only, but the first patient that was published was from Jamie Henderson in Stanford University, and he published, so I can say it, he published big holes in the patient's head, but for whatever reason they thought that 0.5 Tesla rather than 1.5 Tesla was safer.
Oh, okay. Yeah. No, I knew that. I always thought it has to do with the resonance frequencies on the length of the cables. That 3 Tesla is safer. That as well. Okay. Yeah. Interesting. So,
but the RF energy to stimulate the tissue with the Lamar frequency, the frequency. And I have always a story from a child on a swing. Yeah.
Yes.
If you push that child on the wrong moment, you need, as an adult man, you need all your force, and the child doesn't fly.
Yeah.
If you push at the own frequency, one finger, and the child flies all over the whole thing. Yeah. And that has something to do with the Lamar frequency. Yeah.
Makes sense. Fantastic. So, did you also train surgeons, or more the radiologists, or was it like a surgical team as well? Or?
No. If I was invited in a center, then I first checked the radiologist, the images, and then I trained the physician, the neurosurgeon, in use of ultimately the frame link and the planning system, or in many cases, I brought the frame link with me and we did together. I operated the system and the doctor looked at the images and said, I want to have the electrode there and so on. Yeah. So that was training of the neurosurgeons in many, many cases, because actually you could say that very few neurosurgeons were actually in their medical education trained for stereotaxy. There were a couple of old guys, Professor Sturm, and Professor Siegfried, that were the last of the Mohicans, you know, that could do stereotaxy. And then it started all over again.
They had to learn again. Okay.
You had to learn again, and then in a technique with deep brain stimulation that has the biophysics of stimulating. What is the pulse rate and what is the frequency and all these things? Yeah.
Interesting. Yeah, I've been trying to get Professor Sturm on the show as well, but it's been hard to contact him. It would be very interesting to hear from him as well. Yeah. So it must have been a very exciting time. At some point, or maybe are there any anecdotes that you can talk about? You told me that you would only talk about people if it's very positive, which but any at the time training these teams, were there any encounters that you still remember, or that were curious, or that
in the beginning I had to learn a lot. My teachers were Benedict and Polak, and in Amsterdam Professor Dr. Speelman, but he was not a professor, and Professor Bos. He was one of the people that never forgot how to DBS. But DBS with only AC and PC initially. And then going on. So I learned a lot of these things over there in Grenoble and Amsterdam. In Amsterdam, they were really willing to teach me.
Fantastic. So it's interesting that Amsterdam is still one of the really leading centers in terms of numbers and so on. They do a lot of surgeries, including also in psychiatry. So it seems the history there has started early into...
In 1993, there were first implants in Amsterdam. So that was during the clinical study. And they do now, on average, for about 40 weeks in the year. Vacations as well. They do 3 patients a week. And so really they are way over 2,000 patients now. And they did that in a correct way, because if you look at the publications in Amsterdam, there is a whole bunch of New England Journal of Medicine patients comparing thalamotomy versus DBS and things like that. So it was very systematic. Now you have the successor of Professor Bos, Rick Schumann. Rick Schumann is now the professor in India. So I worked very much with him. I remember the very first time that Rick Schumann did his own DBS, and with hands like this, inserting a cannula in the ventricle to add contrast in the ventricle to be able to see AC and PC in the third ventricle. That was the very beginning when he was a resident.
Wow, you were there. Fantastic. And I remember, this might have been a bit later, but when we met earlier on, you also spoke very highly of Volker Kühnen, because he was a pioneer with the DTI, as like pretty early on. You might have been even the first trying to combine tractography with DBS. Was that
Volker Kühnen was a resident in Aachen, in RWTH hospital, and he became a good friend of mine. Because we kind of fitted in thinking process, and he's a brilliant guy, absolutely brilliant guy in my opinion, and I learned very much from him. And then he went to Bonn. From Aachen.
Yes, correct.
And in Bonn, he could not become a professor because it was assigned to someone else who was there, apparently. And then he got a full professor in Freiburg. And he's still in Freiburg. And Volker started deep brain stimulation for depression with his medial forebrain bundle target. And it didn't fly stronger than I thought, because his arguments were pretty good. But I consider the brain stimulation for depression one of the most difficult things that you can do with depression. Because measuring the symptoms is one day this and one other day is that. And so but Volker did that, also partly funded by Medtronic. And I went there numerous times, learn things. Did you ever go to his room?
I did not. No, I studied in Freiburg, but that was before he was there. So I know him well, but I haven't seen his room. So no, I have yet to.
No, I'm not going to tell what you can see over there. If you are going over there, you will see it.
Okay, fantastic. So back to the script. I think one other really breakthrough that you introduced, or at least were part of this, was to introduce microelectrode recording.
Yeah.
Was that really how did that come about? Was that your idea, or how did that work?
Initially with DBS, because of the not known risk, perceived risk, patients were really end of the line Parkinson patients that could hardly cooperate in the operating theater. They were conscious, but they were asked to do this and all the testing of the symptoms. Hardly. Some patients it was impossible to do that. First of all, test stimulation. You needed to know what kind of parameters and things like that. So it was not immediately that the symptoms were gone. Certainly not in STN. Not immediately. And then I learned that Medtronic had a company in Denmark, and it's called Dantec. You know Dantec? No, the name is not known anymore. It's a very famous Danish company in Copenhagen for neurophysiological equipment, mainly EMG and so on. And they had a machine to record single fiber signals, single motor unit fiber signals from muscles. And I realized that the cross section of a muscle fiber is about the same as the cross section of a neuron in the brain. And I immediately realized if you can measure single cells from a muscle, then you can also measure single cells from the brain.
Great.
And my point was, if you can measure it, then it can help the doctors a lot, because you are not 100% relying on the cooperation of the patient to test stimulation. You could already, later with Bennett's technique, but refined, 5 simultaneous microelectrodes, you got a 3D impression where the nucleus was. And if you knew the 3D impression where the nucleus is in a patient, you know also where the limbic and the associative and the motor part is. So you could try to avoid, for instance, the limbic part, and by doing that, the psychiatric side effects of STN stimulation went down, and that was based on microelectrode recording. And actually, over the whole world, doctors accepted microelectrode recording. I think that 80% of all DBS implanting neurosurgeons used microelectrode recording. Nowadays, it is getting a little bit less, because people think that you can do it solely on imaging, because the image is so much better. But in Amsterdam, they evolved to doing microelectrode recording under general anesthesia, where you choose the right anesthesia. That was another training aspect. At some point, we started to do microelectrode recording, and I had to teach the neurologists that they could not give certain medications in the evening before Parkinson medications, and the anesthesiologists don't use benzodiazepines, because then the STN is quiet and things like that.
I'm sure.
And so that was another training aspect. Anesthesiology.
Training microelectrode recording and interpretation is not trivial, I think, right? I've done that a bit myself, and it is not very easy. So I'm sure teaching people and getting experience in it.
In STN, I think it is now, with what we know, easy.
The STN signal is pretty characteristic. You're right.
And in the global spandus internet, you need to do a whole bunch of negative elimination. It's not that, it's not that, it's not that, and it must be this.
Yes.
And I remember that we started in Amsterdam doing microelectrode recording in the anterior nucleus of the thalamus in epilepsy patients. And I saw the lamina, coming from up, and I saw the lamina, and I recognized triplets, quadruplets, spikes firing very shortly behind each other. And I realized that you can measure these things also in the thalamus. And I thought, hey, misschien is that a landmark signal for being in the appropriate part of the anterior nucleus of the thalamus for epilepsy. So we started like that also.
We'll get to epilepsy in a bit. So the Ben Gunn system, that's I think really called after Ben Abid, right? Ben Gunn. Was that like, were you part of the design, or like how did that? Who then created the device to record, and how early did it start with microelectrode recording?
We didn't copy the Ben Gunn because Ben had electrodes that were 2.2 millimeters apart, 5, and the cannulas were so thick that there was almost no space for tissue in between the cannulas.
Oh, I see. Okay.
But we learned from a company in the United States, FHC. Ever heard about it?
No.
FHC in Maine in the United States, who could make cannulas for research. They made them.
Yeah.
And they were stiff enough, stainless steel, and the microelectrodes they made also. And instead of being about 1.8 millimeter outer diameter like in Ben Abid, these were only 0.6 millimeter, and inside was the microelectrode. And that means that you did not get a massive micro lesion when you put these things in the STN. So that is the steps from FHC. And FHC was a very reliable company making microelectrodes, making cannulas, until Medtronic wanted to make money out of it. And that
Interesting. Okay, so we had already covered that you designed and managed major pivotal studies. So we talked about the DBS and the VIM for tremor with 290 patients, and the advanced PD clinical study, which was STN and GPi. Both led to CE mark and FDA approval. And then you did mention to me that Medtronic had an internal fund, which was apparently internally called the Crazy Money Fund. And you got this grant and used it to run DBS for OCD, trial in OCD, which also led to CE mark. How did you come to that? And what was
we knew already, Medtronic knew already, that the biggest cash cow for the pharmaceutical industry is psychiatric medication, and especially persistent depression, where a lot of medications were made, billions of dollars were made by the pharmaceutical companies. And I thought if we could do that with DBS, stimulate somewhere in the brain to treat depression, that was a nice opportunity for Medtronic. But then when I started to talk about these things, also in Germany, I learned that at that time, doing something in the brain of a psychiatric patient was absolutely not done in Germany because of the history of the Second World War. And I still wanted to convince the psychiatrists that the brain stimulation could mean something for them. And then I learned about OCD, obsessive compulsive disorder, which you and I and people who are not trained can see the symptoms very, very well, objectively can see the symptoms. So I designed a protocol and sent it to Medtronic. It's called the Quest, with capitals, QUEST, Quest grant, and it is intended for activities that are crazy in their idea, where the existing Medtronic business units were absolutely not interested. And so I got the money from the top of Medtronic, $50,000 I got to design deep brain stimulation for obsessive compulsive disorder. We started with that in Leuven with Professor Nutain, you know him.
Yeah, of course,
And ultimately also with a couple of centers in the United States, and we collected the data and sent it to the CE mark authorities, and they said yes, you can get a CE mark. And so that was how we got a CE mark for DBS for OCD, with my intention to show psychiatrist that there is something else besides medication.
Yeah.
And when we got that, it came very close for Medtronic management to decide, way too fast in my opinion, to do studies on deep brain stimulation in the United States for depression, which both failed from Boston Scientific and from Medtronic, because the design was, in my opinion, now I should not say that the design was not good, but the disease is so complex that measuring the symptoms in an objective way, it was way too early to do that.
And so Professor Newton is now famous, I think, for the being a big nucleus of striatum terminalis target. But back then it was the nucleus accumbens, correct? In your trial that you targeted. So my main question is how did you define the target? Because it was a first in-human attempt to do this.
I think we always stimulated in the bed nucleus of the stereotactic terminalis.
Okay.
Which is very close to the nucleus accumbens.
Yes.
And it is actually a fiber bundle. Yeah. We know if we stimulate in the brain, that the lowest thresholds are for axons and not cells to stimulate. And so I started to believe that one of the inputs and outputs, which is parallel, is the bed nucleus of stereotactic terminalis, but the fibers going in and out to the nucleus accumbens, among others. That was the choice to use it, and it was. I trained doctors that wanted to do DBS for OCD, also in whole Europe and the world. I trained them how to go to the bed nucleus of the stereotactic terminalis. That was a very rigorous, systematic, step approach that I learned from Professor Newton.
Okay, interesting. And so it was probably you brought the idea and the funds, and then together the team would decide where to even go in the brain. I find that very fascinating because it hadn't been done before, right? There were
but Professor Newton had, the predecessor of Professor Newton was. He was the predecessor, and he did already some of these psychosurgeries, lesioning, and Newton followed by DBS because he believed in DBS for this technique because it is reversible. And
so I did email with Marwan Harris just by accident this week, and he did mention that I'm going to interview you, and he's been on the show a few times too, and I asked if he has a few questions, and now I think one of his questions that I didn't share up front with you is would fit really well, and he essentially said that Frans, the issue of DBS for OCD was from the beginning your idea, and you approached several psychiatrists and neurosurgeons in Europe. Who did you approach, and what was their reaction to that proposal? And then maybe I read a bit more. Eventually it was neurosurgeon Bart Notin from Belgium and neurosurgeon Meyerson from Sweden who contributed with some psychiatrists, and the seminal paper in Lancet in October 1999. And then subsequently there are two papers where you also are co-author. But since this OCD DBS was your idea, why are you not co-author on the first paper but only the long-term papers? And why were there even ethicists on the paper but not the person that had the idea?
Professor Newton is a friend of mine. But it doesn't mean that others who participated, other doctors who participated, you mentioned, were not feeling happy that there was an engineer on that paper.
From an industry background.
Yeah, and industry background is very important because I will tell you with DBS for epilepsy what that means, because doctors thought that the Lancet paper would be considered biased if there was an employee of Medtronic involved.
Okay.
And I had peace with it.
Yeah. Okay.
You know that we got a patent also based on that. Newton and myself, we got a patent, deep brain stimulation for OCD.
Okay, so you are listed there. That's great.
Yeah. Yes.
And I imagine, working for industry maybe papers are not even that important, right? Patents, I'm sure, are more important than that.
Patents are very much important.
Yeah.
I learned that in the beginning when I was Medtronic, maybe the third year or so. Medtronic, that they say, hallelujah, we won a patent suit from Siemens about the use of something in cardiac stimulation. Siemens has also pacemakers. Yeah. And I learned that we got $3 billion over a period of 10 years from Siemens because they invaded our patent. But there are numbers that are way higher. So I learned that patents, even if you don't use the technology yourself, you can license them, can be very important financially for Medtronic. And so then I started to write patents, and I maybe I have 60 ideas that I wrote down, and I have 35 international approved patents.
Wow, that's really impressive.
And it became a kind of a sport.
Yeah.
I never did something that was linked to research where I didn't think, hey, is this brand new? Could it be brand new? No. Leave it to the patent lawyers in the United States to judge that.
Yeah, okay.
Yeah.
Fantastic. Did any of these patents, become, I don't know, widely used or also is there personal benefit if you have patents? The
benefits, that could be millions and millions of billions of dollars for Medtronic. The inventor in Medtronic got first 750 euros tax-free. If the company decided that they were going to file the patent, and then when the patent lawyers, I was involved in patent lawyers and writing text, imagine, it is unbelievable what you see there. And if you got officially a patent approved by the American patent authorities, then you got another $750. So it was $1,500 for every patent, times 35,
It's not nothing, but it's also not a lot.
No, it's not a lot compared to... but that was in the Medtronic labor agreement, that anything that you learned over there is owned by Medtronic.
Yeah. I guess it's probably normal for most industry contracts.
I'm going to... If you permit, I'm going to tell you a story. At that time, I had 3 small kids. I still have 3 kids, but they are not small anymore. And we went to one of the Waddenzee Islands, Terschelling, Wattenmeer Islands in the north of the Netherlands. And we went there 14 years or so. And at some point, in the middle of the night, I made a walk along the beach to the very, very southwest of Terschelling, which is an enormous plate of sand with low tide.
Yeah.
And when I walk back to the village, Westerschelling is where the ferry is also, every time that the beam of the lighthouse struck me, I mean, can you imagine you are in the middle, almost in the middle of the sea on land, you are totally blinded by the light. And then I thought, if we can steer currents in DBS, the brain stimulation, we may be able to be more selective in stimulation. So that was my patent window DBS electrode, like if you see how a lighthouse works, rotating light or a windowed light where the light turns around, and then you have a beam in a certain direction with a certain timing. And I got the patent approved in 2001.
Wow, okay.
And internationally approved. I can show you on my computer. And Medtronic was not interested.
Really?
Medtronic was not interested. No. Then other companies like Boston Scientific and St. Jude, they saw my patents. They see all these patents, and they kind of worked around it. And they got segmented DBS electrode, and it was all over. Medtronic business went down very, very much because it is, sorry for the word, but it is a segmented DBS electrode, that you can steer. Yes. That is pretty sexy.
Of course.
Yeah. And so customers bought en masse DBS electrodes from Medtronic.
Yeah.
From St. Jude and Boston Scientific. And then Medtronic decided in 2000, and I wrote it down somewhere, 2009, to do a clinical study in Kiel, because they were very good in relationship with Jens Volkmann, and it was not so much that implanting the electrode was the same as a normal DBS electrode, but testing side effects and whether the segmented electrode could indeed evoke different symptoms. And that was a blatant failure. Why? Because it was done in Kiel. I was 6 hours driving from Kiel, but they chose a managing engineer in Minneapolis who didn't know what he was doing because he used the Medtronic CE marked and approved external stimulator that mimics the iTrod 2 and that was tailored to 1 kilo ohm load. DBS electrode, 1 kilo ohm load. And then you could stimulate to 10.5 volt. That came from spinal cord. That was internally technical. 10.5 volt. And then you could stimulate with a stimulation current that was doing everywhere its job in DBS. Until we got the segmented lead. And they did a clinical study and wanted to use the same stimulator, 10.5 volt, on an electrode that is only that is 4 kilo ohms. And you could not stimulate more than 5.5 to 6 milliamps, which was insufficient, and therefore they couldn't do what the study protocol required, looking at side effects in certain directions. And it was a dramatic failure.
Interesting. So in that context, maybe it would be worth briefly touching upon the acquisition of Sapiens, where you talked about the windowed approach. There was a pattern. Medtronic wasn't maybe interested, and then I think they wanted to maybe even jump to the next even better model with 30 contacts, but which was ultimately discarded.
Yeah. The technique from Sapiens was just like making integrated circuits. And integrated circuits, not ICs, but circuits that are on a flexible bearer. And so they did that. They made with the same technique as they made electronic circuits. They made contacts, and then they could roll it up, and then it looked like a DBS electrode, and you could inject it in the brain or insert it in the brain through a cannula. All these things were well designed, but biocompatibility is an issue. And if you have this plastic that you use for flexible electronics, to make that biocompatible, when they did research, that was not going as quick as they wanted, not going as quick as Medtronic wanted, and things like that. And so within 2 years after Medtronic bought, and Medtronic also pulled the plug, and they fired all the people.
Very interesting. We had talked about all your clinical trials that all led to CE marks, including OCD. Anything you learned from the OCD study that was maybe interesting, or any anecdote you want to share before we move to the next disorder?
Medtronic was from the beginning not really interested in DBS for OCD.
Okay.
They were kind of surprised that we got on relatively few patients a CE mark approval.
Okay.
And actually, in about 3 years ago, Medtronic, you need to renew.
Yes.
And Medtronic,
they lost it.
They lost it. They were so little interested that a CE mark that they could use whatever in the future, they simply let it go. That means that you now have to do a clinical study according to new rules, far more expensive than at that time.
Interesting. Okay, and then you also in 2010 you started and managed a clinical study in DBS for epilepsy, which also resulted in a CE mark. Study enrolled 196 patients in Europe. What were key outcomes? How did it even come to pass that you looked into epilepsy?
As a physicist, I like networks, and I realized that epilepsy was a network disease where sometimes network fail, get epileptic symptoms, and sometimes the brain is completely normal. And I found that enormously intriguing, and especially the timing, the temporal and network features. And when Medtronic asked me whether I could do DBS for depression or DBS for epilepsy, I chose wholeheartedly DBS for depression, for epilepsy.
For epilepsy,
And then we did a clinical study in Europe. Went relatively fast, 190 patients. And what I did for DBS in OCD, where manually I characterized the place from where the target was, in the brain that is big and small. At that time there was no software that could stretch the brain.
Sure.
And Thomas Brion was my colleague in Switzerland. He was very, very happy with the technique that I used for OCD, and he asked me, "Can you do that for epilepsy also?" It's basically manually, locally stretching based on landmarks that you can see, and then ultimately decide where the electrode is. It was pretty successful. I got for that all images that the doctors collected I required that in the clinical protocol that they needed to give me a copy of all images, which is not a no-brainer because there is patient privacy and so involved.
Of course.
But I signed non-disclosure, whatever. And so I did that for epilepsy also, 196 patients or so. And Medtronic, Thomas Brion, my colleague, and also some colleagues in Minneapolis were really satisfied with it. And then someone said, "Yeah, but you can never publish it because it is done by a Medtronic employee, and the journals will say that's strictly biased." And then they said, "We need to let it be done again." And then they asked me whether I had a suggestion, and I proposed Professor May in Düsseldorf because I used Professor May's brain atlas for all my work. And so there was a contract with Professor May and Medtronic, and I went there with my frame link because all the images were on the frame link. And it would cost tremendous amount of time to get the images on another machine from May. So I was sitting there with Professor May in his private house close to the University of Düsseldorf.
I've been there actually recently.
Fantastic. You're treated with all kind of lunch, godly stuff. He's absolutely a gentleman.
He's fantastic.
And I went there initially together with my colleague Matt Eastburn, who's now in Australia for Medtronic. And when we started there at 10 o'clock in the morning, and the whole day we were working with patient by patient by patient, evaluating whether his naming of a target would be the same as what Frans Gielen did. And more than 80% of the patients we were 100% matching.
Great.
And others were because he knew far more microstructures in the name. That was I do not remember that I made somewhere a mistake. And we started at 10 o'clock in the morning. We left Professor May's house at 10 o'clock in the evening. And we did half of the patients, 196, not even. And when we drove back, Matt Eastman and I, we said, we both, and I was really strong in it, I had the impression that I was back in my student age and working together with a professor in my doctoral phase, very intensely working together. And that was the feeling that I had working with Professor May. Very informal, but strictly scientifically. And
Dr. Medtronic probably.
Medtronic was working on his own stuff. And at some point he wanted to show us something, and I stayed working with Professor May, and Matt Eastman, who know more about computers than me, sat with Milan in the same house behind Milan's stuff, and that resulted in the publication that I sent you. A network publication.
It's a fantastic paper.
40 pages or something like that. Pretty extensive paper. And that was what Milan Medtronic did for us.
Fantastic. So maybe for the listeners, this is the paper where your co-author, Dr. Medtronic, and Professor May, I think Volker Köhnen as well.
Volker Köhnen also, and a Swedish doctor, a Finnish doctor, I think.
And it is about the connectivity of the thalamus, and especially the ANT, right? The ANT nucleus. Where you, I think, applied a really cool approach to use anatomical knowledge, but still put it into some sort of three-dimensional stereotactic space, right? To do that. And you wanted the
MNI atlas. I was very intrigued and interested about. I learned almost as much in the beginning of my studies.
Great.
Yeah.
You had some thoughts about a broader brain networks hypothesis of the brain as a stochastic system, and that was also formulated in that article. Do you want to talk a bit about these ideas?
I was struggling and dreaming often. I could not understand for myself that the brains of human beings did not grow noticeable bigger since basically the Middle Ages.
Yes.
But we realized that now our brains can cope with terabytes of extra information. Yeah. And I could not understand that evolution would have created a brain that for everything that you learn there was a discrete storage point. Yeah. Despite of the huge number of brain cells.
Yeah.
And so then I thought, and based on my thermodynamic studies, that the brain, depending on the input, and the idea came from a baby crib. On top of that you have a mobile, and now consider the brain as enormously more bigger, mobile. But the essence is, no matter where you pull or push on the mobile, everything will move, more or less, depending on the gain factors.
Yes.
Yeah, and that means, in my opinion, that is what I dream about. That the brain, a certain structure in the brain, can sometimes, depending on where the equation is, can do a certain job. Yeah, and in another moment, when the inputs are different, can do the same brain structure, can do another job.
Yes.
Yeah. And so this is what I think about, and I consider. Sometimes I cannot sleep. I dream about it, and I try to understand more and more about it. And
it's a very fascinating thought. I mean, for memory, I think these associative ways of storing data have been theoretically worked up in smaller systems, right? That seem a bit like that, I think, where single neurons would, again, depending on the the active network, can form part in different networks for different purposes, overlapping purposes. And I assume even the grid cells in the hippocampus that can always rewire and adapt to the new.
Whether it is rewiring or
not rewiring. Sorry, functionally rewiring. Right? That seems to be like this, right? I totally agree with you. That it's not like one neuron is always the grandmother neuron or so. Or
I don't believe it's impossible. There could be not enough brain cells compared to the terabyte of extra information that
evolution would have never created it, as you say, right? It would have never, because there was no necessity for our modern.
So evolution would never do something that had no benefit. It never had benefit. Maybe there are disadvantages that we know now. So much information. This is what I believe that the brain should kind of work. And you can only believe that if you also accept that the brain is not a discrete machine, but a stochastic machine, depending on millions or hundreds, thousands of inputs. It weighs it, and it comes to a certain outcome.
Yeah, I think also information is typically represented by populations of neurons, not by individuals, right? So that is a similar thought, maybe, that it's never a very discrete or
and what we underestimate is we make images, MRIs, CTs, whatever images. What is missing with these things is time information at the speed of firing axons, milliseconds speed. None of the images has the ability to create a new image with the time constant of a millisecond.
Absolutely, yeah.
And none of the images is looking how the integrating of the intermediate cells, or what is the name of these cells? All the cells that support the brain tissue, but also feed the cells. Yeah, I forgot the name for a moment in my enthusiasm.
Yeah. Great. Yeah.
So none of the models that we use and bring forward is using appropriate time constant, very small time constant, and integrating circuits like the cells that are feeding glial cells. Sorry for that.
No. Okay, now I get it. Okay. Yeah. Interesting. Yeah. But isn't it fast? I mean, the fact that evolution could not have foreseen our modern lives and it still works, isn't that fascinating?
That is absolutely fascinating.
Maybe a small anecdote here. My father, unfortunately already passed, but was very much a scientist in mind. He was an eye doctor, but he was very much interested in science, and he always had these thoughts also about the brain and these things. And he always told me, nonetheless, to what you just said, if you ever come to heaven, ask them for a bigger hard drive, because he always felt our brain is not it's too capacity limited.
But that was then probably based on the fact that we thought that we had discrete things and discrete circuits that did only one job.
Yes.
And I don't believe that is the case.
No, you're and he wouldn't have either. But it was more, of course. But I think still more storage would be even desirable, right? So to be able to memorize even more would be great, because we forget so much, don't you? Don't you?
Yeah. If you get older, you forget so much. But there are wonders in Christian beliefs. Yes, a sheep herder somewhere in the Pyrenees, goes to a grotto and sees Maria standing over there. Yeah. Why does the brain do that? Depending on the inputs and her religious whatever beliefs, she creates an image of Maria. Yeah, that is how I think a lot of wonders are generated.
I agree.
Yeah. And then the brain is unbelievable what the brain with different types of inputs can create, in my opinion.
Yes, absolutely. So just a few more questions to close. How does in your opinion, how does the field of neuromodulation and functional neurosurgery of the future look like?
I wrote down here for myself that the brain is essentially an electronic network, and therefore I believe that this network, when you modulate it electronically, you can do unimaginable things.
Yeah.
Especially, and that is what I wrote explicitly, if you activate the brain in a similar stochastic behavior as the brain itself. And then it has a great future, in my opinion.
Yeah. Okay. Any eureka moments that you had in your career?
Yeah. The first time that I was recording in an epilepsy clinic here in a little bit north, specialized epilepsy clinic, we had the percepts in the patients. You could record from the electrode, and I had electronic tools that I could read live out, and the patient had the classical epilepsy network, 64 electrodes. Okay. And I was sleeping on a stretcher in the room besides, but I got a beep when the patient got a seizure.
Oh, wow, okay.
And I went and I read the information out, and it was unbelievable. That was an eureka moment, how well there was a coordination with what we registered with the DBS electrode and what the outside EEG said.
Okay,
yeah.
Wow.
That was, for me,
I'm sure.
Absolutely a eureka thing. Yeah.
Great. Any time in your life where you thought this was a waste of my time or didn't go well?
Trying to convince Medtronic that DBS in epilepsy is the technique, the disease to start adaptive stimulation with percept, because epilepsy is an episodal disease. Well, Medtronic decided, okay, we do this adaptive stimulation in Parkinson's disease. Well, never, ever, ever we saw dramatically better results than what we typically see in patients. And Parkinson's disease is a kind of a tonic disease.
Yeah.
Why don't you start in a disease that is very important,
Paroxysmal,
episodal epilepsy, with a device that said, okay, now comes a seizure and now I know how to interact. That was...
Got it.
Yeah.
Any advice for young people entering your industry field or the field in DBS? You
asked for a neurosurgeon, huh? Doctors.
I did, but I think for you more appropriate would be for industry jobs in the field, but whatever you find more.
For a physician, I wrote down team up with a physicist.
Yeah.
Because if you realize that almost every important improvement in medicine is there where physicians work together with physicists, MRI, whatever.
Yeah.
All examples like that. So team up with a physicist if you want.
That's smart. I like that. Yeah.
Yeah. Because it is completely different, but very much supporting on medicine. Yeah.
Where do you see the future of the field?
I wrote down that if you stimulate the brain, you should do that more with a stochastic technique to accommodate the stochastic brain.
Okay. And then any missed opportunities of the field? So maybe, not in your life, or as you want, but what is the field not doing it should be doing?
I like my job in Medtronic, 30 years. I liked it so much, I was dedicated so much, that now I realize more and more that when my children were small, I didn't see them enough to see them growing up. That is missed opportunity.
Okay. Is there any topic you would have liked to discuss that I missed?
I put emphasis on what Jung is, and I wrote down I worked for 30 years in DBS in Medtronic, and now in about an hour you want to know. So you missed many things.
But I kept you for a very long time, so thank you so much for bringing up so much time, Frans.
It's absolutely a pleasure.
It was really fantastic. Yeah.
Okay, good.